Now today we'll be discussing about the main uh, chest X-ray differentiation, that is pneumonia versus pleural effusion. Now the thing is definitely clear that most of the time effusion can be because of the underlying pneumonia, or it can be simply pleural effusion. So effusion, if the patient has effusion, the patient may definitely have underlying pneumonia or underlying consolidation or underlying a lower respiratory tract patch, and that can be very commonly associated with effusion. Else, the patient can simply have effusion without any consolidation. So that can be because of fluid overload, that can be because of LVF, or that can be because of CKD, AKI, because of the hypoalbuminemia. This can be so many causes for that pleural effusion. So whether the patient has only effusion or a consolidation patch, it is very difficult to say. But see, whenever a someone has a pleural effusion, and if that is mild to moderate to severe, most of the time, if the patient has severe effusion, or if you start with mild pleural effusion, these are the costal ribs and this is diaphragm. So this is the costophrenic angle. Phrenic means diaphragm, and this is the ribs. So the as soon as there is a mild pleural effusion, this angles get blocked. This becomes white, as we can see in this right side. Now, in this right side, this angle is nearby here, but it is completely blocked on the right side. So this is all hyperdense, or there it is all radio opaque. So this all is pleural effusion for sure. So here effusion is there for sure because this angle is completely blocked compared to the costophrenic angle on the left. So this left is kind of okay, open, but on the right side it is completely blocked. It is already opaque. It means there is accumulation of effusion or fluid in this right. So effusion is there for sure. But as we say, if you have to say a moderate pleural effusion, which we can see there is a radiopaque patch here also. If this is only effusion, it should show a meniscus sign. It means this, as we know, the pleura are present here. The pleural cavity is here. So, and the lungs are here. So in between this, we have a pleural cavity. So if the effusion is there, it should climb along this line. So we should get a very nice pleural meniscus. So the pleural effusion should present like this. So if it is definitely pleural effusion, you should have a meniscus or a curve-like radio-opaque line or shadow that should increase, or that should go around the pleural cavity. So this is a very typical of pleural effusion, but in this case, we don't have that thing. We simply have a radio opaque patch here. So what is patch or what is consolidation or pneumonia? We call it as consolidation for pneumonia. So consolidation or pneumonia is a homogeneous radio opaque patch, homogeneous radio opaque patch over a translucent lung shadow, lung shadow, where uh, it will be 100% diagnostic if you could see the air bronchogram. Air bronchogram is actually a presence of air in patent bronchi along with a homogeneous patch on the background of translucent lung shadow or translucent lung. Here, the meniscus sign is not there. This angle is definitely blocked, means there is definitely a mild right-sided pleural effusion. But what we have is a radio opaque patch in right lower lung field. So this is a very, very typical pneumonia or consolidation which lacks the meniscus sign, but it has definitely a patch along with the right-sided pleural effusion. Now, when we see it in here, this is a different patient, different X-ray. Now here we can very easily make out that this right costophrenic angle is open. See, this is not blocked. This is open, and the left pleural effusion is the left-sided costophrenic angle is definitely blocked. So here is effusion. Effusion is there for sure. Now we have a very beautiful meniscus sign which we can very easily appreciate. So this is the typical meniscus sign. Just see this line. You can very nicely make out that this effusion is actually increasing or is going above along the pleural cavity, along the rib margins towards upside. So this is a pure pleural effusion or accumulation of water that is going along the coastal margins. So this is a very classical pleural effusion where we don't have, at least the consolidation or pneumonia patch is not visible. That may be visible only on HRCT chest. On CT scan chest, we can see that patch which can very easily identifiable, or we can simply tap this pleural effusion, and if the fluid goes off, maybe we'll be able to see the pneumonia. Now, how to differentiate the pleural effusion versus pneumonia on clinical grounds? Now, this is very important and very fascinating as well. In pneumonia, basically, the lung alveoli are all filled with protein material or exudate. That is the reason why these alveoli actually become more of like solid organs. So through this, the sound travels very well. So what we can hear through auscultation is there is an increased tactile vocal fremitus. What do you mean by this is in if the patient has pneumonia and if we auscultate through the stethoscope and if we ask the patient to say a resonating sound like 9 in a same monotonous voice, if there is pneumonia underlying the effusion, the sound of 9 will be more pronounced than the other side. Whereas it is if it is only pleural effusion, in pleural effusion because of the fluid, the sound travels poorer. So this 999 sound will be audible, but it will be much lesser audible than the normal side. So you auscultate here, you ask the patient to say 9 in a monotonous pitch, and then again auscultate the same sound here. If you can auscultate this sound in a louder way, it means the patch is here. Or if it is lesser than this intensity sound, it means that there is very unlikely to have any consolidation. It is only and only pleural effusion. The same goes with the whispering pectoraloquy. So what is whispering pectoraloquy? It is based on same principle that you ask the patient to very mildly whisper a number like 9, which cannot be actually heard very well or very loudly outside. He simply has to whisper only in his mouth, and we had to auscultate that sound on the lungs. So if you have to again compare that sound from here to here, so if it is consolidation, the sound travels much well through this larynx where the sound is generated, and it travels to that pneumonia patch very well, so that even though we cannot hear that sound from outside, but through the stethoscope we can hear that sound very loudly and very clearly. If we can clearly understand comprehend that number through the stethoscope, then it means that patient definitely has the consolidation underneath. And if the consolidation is not there, the sound will not be well audible. Other points which definitely helps us for differentiating pneumonia and consolidation, pneumonia and effusion is consolidation will not push the mediastinum or trachea to the opposite side, whereas in pleural effusion, it will definitely push the mediastinum or the trachea towards the opposite side. One more interesting thing is patient prefer lying down on pleural effusion side. So if the patient has the left sided pleural effusion, the patient like to sleep on the left lateral position. So these were all the points which can help us to actually confirm whether there is only consolidation or patient may have underlying consolidation and effusion, and some points to differentiate this pneumonia with effusion clinically. Thanks for watching. Thank you.